Hi everyone, I'm Dr. Mohammed Jamal Faisal and I'm going to be talking a little bit about acute aortic dissections. While they're fairly uncommon, they can be catastrophic disorders. So patients will present with a tearing chest pain that often radiates to the back. Now it's essential to be able to differentiate aortic dissections from other causes of chest pain. Now, that being said, this is one of those high-yield topics that tend to pop up in MCQs, whether you are a 4th or 5th year medical student or you're taking your postgraduate licensing examinations. So this really is one to pay attention to. In this video, I will be talking about the classification, the clinical features, diagnostic tools, the differentials, and of course the management of acute aortic dissections. So stay tuned. Right, so what is an aortic dissection? Well, the name sounds long and fancy. In really simple terms, it just means splitting the wall of the aorta to form a false lumen into which blood pools. So that being said, who all are at risk? The first thing that tends to pop to mind is trauma patients, but they're not the only ones. You have the elderly. You have people who have atherosclerosis and hypertension. Another very interesting association of aortic dissections is Marfan syndrome, which happens to be a genetic connective tissue disorder. The people suffering from this condition tend to be quite tall, and they have a slender frame with disproportionate arms, legs, and fingers, as you can see in the picture. Other connective tissue disorders such as Ehlers-Danlos syndrome, giant cell arteritis, and systemic lupus erythematosus have also shown connections to aortic dissections. Now, Ehlers-Danlos syndrome is characterized by very stretchy skin and hypermobility and flexibility. And giant cell arteritis and SLE are autoimmune disorders often seen by rheumatologists most commonly. Coarctation of the aorta is a narrowing or a constriction in a portion of the aorta. Now what that does is it forces the heart to pump even harder so that that blood can get through the aorta and then supply the rest of the body. This is also something that can lead to an increased shearing force that can precipitate in an aortic dissection. Other genetic conditions like Turner syndrome and Noonan syndrome, they also play a role. Turner syndrome is exclusive to females, as it occurs when one of the X chromosomes is missing or partially missing. Turner syndrome can cause a variety of medical and developmental problems, including short stature, failure of the ovaries to develop, heart defects, and Noonan syndrome is also characterized by multiple craniofacial disorders, and short stature are also associated with heart defects and other physical problems and developmental delays. Pregnancy and delivery can also precipitate in aortic dissections, most commonly in the 3rd trimester or at the time of delivery, of course. Now, this is due to the hyperdynamic state that pregnancy induces and the hormonal effect on the vasculature. In addition to this, you have people who have a family history of aortic dissections. And of course, any activity that results in an abrupt, transient, severe increase in blood pressure can cause an aortic dissection. Whether that's strenuous weightlifting, whether it's the use of sympathomimetic drugs, maybe cocaine or ecstasy, or even energy drinks. Infections like syphilis have also been noted to cause aortic dissections. And another really important point that I've not mentioned yet is the iatrogenic causes. So any aortic instrumentation or surgery can precipitate in this, whether it's a coronary artery bypass, whether it's aortic or mitral valve replacement or percutaneous stenting or any catheter insertion. So all of these can potentially lead to aortic dissections, and therefore these procedures do stand as risk factors. So let's talk about blood vessels. Blood vessels have 3 layers. They have an intima, a media, and an adventitia. Now that's going from inside to out. Now, constant exposure to high pulsatile pressures can then lead to a weakening of the aortic wall in susceptible patients like those mentioned earlier. Now, this can then result in that intimal tear. So a tear in the intimal layer can result in progression of the dissection due to the entry of blood in that intima media space, which then creates our false lumen. Most of these tears tend to take place in the ascending aorta, usually in the right lateral wall, because that's actually where the greatest shear force on the aorta actually occurs. Now, these dissections can propagate in an anterograde direction or a retrograde direction. Now, depending on the direction the dissection travels, our spectrum of symptoms then varies dependent on that. Now, there is also a possibility of rupture. Now, it can rupture back into the aorta, or it can rupture into the peritoneal cavity, the pericardial sac, or the pleural cavity. Now, rupturing into the aorta is quite rare, but it actually has a better prognosis because it then produces a double-barreled aorta, so to speak. Now, let's talk about the classification. So aortic dissections are broadly sort of classified into two, by either the Stanford classification or by the DeBakey classification. So the Stanford classification classifies the dissections into two types, type A and type B. Now, this is dependent on whether the ascending aorta is involved or the descending aorta is involved. So type A involves the ascending aorta, regardless of the site of primary intimal tear. The type A dissection is defined as a dissection proximal to the brachiocephalic artery, whereas a type B aortic dissection originating distal to the left subclavian artery and then involves only the descending aorta. Now, the DeBakey classification is a little different. It talks more about the site of origin of the dissection. So type 1 originates in the ascending aorta and then to at least the aortic arch, whereas type 2 originates in and is actually limiting to just the ascending aorta. And then type 3 begins in the descending aorta, but then it extends distally above the diaphragm in type 3A or below the diaphragm in type 3B. And so now that we have an idea as to what an acute aortic dissection is sort of classified into and the basic principles behind it, we're going to move on to the clinical features now. So the classical picture for an aortic dissection tends to be with a patient coming into the emergency room with a sudden, sharp, tearing pain in the chest that radiates to the back. Now, that's the classic picture. But the actual presentation is highly dependent on the extension of the dissection. So as the dissection, wherever it extends up to, it can actually cause branch obstruction of the affected area or territory, then resulting in ischemia of those vital organs. So say, for example, the dissection were to extend to the level of the renal arteries. The patient would present with flank pain and also signs of impending renal failure. Or if it were to extend to the mesenteric arteries, the patient would have abdominal pain and signs of bowel ischemia. If it were to extend to the spinal arteries, the patient might have paraplegia. And if it extends to the iliac arteries, we might see things like leg pain, pallor, decreased distal pulses, and limb ischemia. And so if the dissection were to then propagate in a retrograde direction, we might see the extension of the dissection going towards the head and neck vasculature, which may give us signs of a stroke, or it might even mimic a transient ischemic attack. If it then propagates to the coronary vessels, we might see signs of an MI, of a myocardial infarction. Or if it even propagates to the point of the aortic root, we might see things like aortic regurgitation, aortic rupture, and even acute cardiac tamponade. So some of the physical signs that we might come across, you're very likely to see that this patient would have hypertension at the time of arrival, unless, of course, the patient's dissection has ruptured, in which we might see hypertension. Whereas in these patients, we can expect a wider pulse pressure because they tend to be hypertensive, and we might find that they have a blood pressure of, say, 200 by 90 or 200 by 110, so to speak. Now, clinically, speaking from a clinical and an examination point of view, The concept of having a varying blood pressure in both the upper limbs is one of the key pickup points in diagnosing and gaining that clinical suspicion for an aortic dissection. So they say a difference of more than 20 millimeters of mercury is suggestive of an acute aortic dissection. It's a difference between both of the upper limbs. So that's one to keep note of. So we may also find things like muffled heart sounds or distended neck veins if there's also an associated tamponade. We might find that the patient has gone through syncope or has altered mental status or Horner's syndrome if the head and neck vasculature is also affected. A diastolic murmur might also be present if there's also aortic regurg at the time. We might find that there's a loss of peripheral pulses or decreased intensity if the dissection has extended quite further distally down the aorta. And we also might find tenderness in the abdomen if there are signs of mesenteric ischemia as well. So just to summarize, it's important just to remember that the clinical features of anyone suffering with an acute aortic dissection vary based on the extension of their dissection. So that's important to keep in mind when you're either in the exam hall or the emergency room. Right, so now that we've looked over the classification and we've talked about the clinical features of someone suffering from an acute aortic dissection, let's look into some of the tools that we use to diagnose these patients. And so they can consist of X-rays, ECGs, CT scans, MRIs, and also standard blood work and lab tests. So let's talk about the X-rays. The X-ray may show a widened mediastinum of more than 8 centimeters to be specific, or it could show a fluid collection in the hemithorax due to rupture. We might also see signs of deviation of the trachea, the esophagus, and depression of the left mainstem bronchus. And so, of course, we will also be sending some blood work and labs. So that might include a complete blood picture, electrolytes, troponin, D-dimers, renal function tests. But the most specific test we can send is a smooth muscle myosin heavy chain assay, which is the most specific for acute aortic dissections. So the ECG will show non-specific signs or might not even show any signs at all. However, it's worth noting that the presence of ECG findings consistent with an acute MI occurs in 8% of cases of aortic dissections. So we can't use an ECG to exclude the possibility of an acute aortic dissection. Now, if the patient is stable, a CT scan with contrast is recommended. The spiral CT can quickly detect the location of the intimal tear, and the advantage that gives us is that it can help the surgeon to plan the procedure. Now, it will likely show a double lumen. It might show the intimal dissection flap, the regions of decreased perfusion, and if there's a contrast leak, that's how the surgeon will know that there is a rupture. And so if the CT fails to give us the information we need, a transesophageal echocardiogram can be done, or an MRI could be done as well. So now that we've gone over the diagnostic tools, what are our differential diagnoses? So very high up on the list, we'd find a myocardial infarction. The reason for that being is that the most common presentation for an MI is central crushing chest pain that radiates to the shoulder or the jaw. And so that can be quite similar to what we're seeing with aortic dissections. Now, most commonly we will find ECG changes in an MI. We might not find them, but we'd also find consistent labs such as the cardiac biomarkers being elevated. Now, abdominal aortic aneurysms are another differential that we have on our list, especially for those dissections that reach the mesenteric arteries. So we could sort of differentiate between the two using a CT angiography that would show us a dilatation of the aorta in the abdominal region if it were to be an aneurysm. You wouldn't see the false lumen that we see in dissections. Now, cardiac tamponade, we said, would occur if there was a proximal extension of the dissection. We would find we would find distended neck veins, and we'd find muffled heart sounds in that case. But it could be due to other causes such as viral causes or autoimmune disorders or post-MI. So it's very difficult for us to sort of isolate that. But the one thing that might help us differentiate the two is that the blood pressure in both the arms might be the same in the case of a cardiac tamponade not due to dissection. So another potential differential diagnosis is esophageal rupture, which could be due to Boerhaave syndrome. That will also present with a substernal sort of chest pain. Spontaneous pneumothorax is also one of the differentials, but that can also be ruled out by the presence of a hyperresonant chest wall on percussion, and obviously through x-rays and other signs. TIAs and strokes, that's veering into the sort of neurological side of things. And so that has its own, it could be due to the dissection, or it could be otherwise. A CT scan of the brain, a plain CT scan of the brain could give us information about that. Mesenteric ischemia and bowel perforation. Now, if the person was to have a bowel perforation, an erect X-ray would show air under the diaphragm, and pulmonary embolism is another one of our possibilities that can be ruled out using a CTPA. And other thromboembolic disorders, obviously we'd have to go through the sort of coagulation profile and specific clotting factors, and it's a long and extensive topic, but that's also one of our main differential points, as it can lead to ischemia of certain organs and areas of the body. So these were just a few of the conditions that an aortic dissection can mimic. But the most important one, of course, I think it'd be important to remember, is the myocardial infarction and abdominal aortic aneurysm. These should be quite high up on your list if you're asked in an exam, or when you're working in the emergency room. Right, so now we've gone over the introduction, we've seen the classifications, we've seen the clinical features, the diagnostic tools, and the differentials. How do we manage it? So the aim should initially be to lower the blood pressure to begin with, so that there's no further extension of the dissection. Now, once we have the diagnosis of an acute aortic dissection in mind, an urgent cardiothoracic or vascular surgery consultation should be obtained. Regardless of the location or where we think it is, it has to be done, because an acute dissection is considered a surgical emergency. So that being said, the patient should have an IV line in place, there should be regular monitoring of his vitals, and ideally a Foley's catheter should also be inserted so that we can assess the urine output. Meanwhile, we should commence the medical therapy. Now, this includes adequate analgesia. Now, the best analgesic agent would be morphine, as it actually, as well as decreasing the pain, it decreases the sympathetic output. Now, decreasing the sympathetic output means that it will in turn also decrease the blood pressure. Now, we should also be administering short-acting IV beta blockers to ideally aim for a heart rate of about 60 beats per minute. So reductions in the heart rate and the blood pressure can actually reduce the aortic wall tension, therefore further limiting the extent of our dissection. So we might come across some patients who have contraindications to beta blockers, like asthmatics. So what do we give them? We will give them non-dihydropyridine calcium channel blockers, which are quite effective for rate control. An example of these very common is verapamil or diltiazem. Now, if after all of this, the systemic blood pressure remains elevated, we will then give them nitroprusside. And so that will give us, hopefully bring the blood pressure down to our goal of 100 to 120 millimeters of mercury. Now, we'd like to maintain the blood pressure in this range for as long as we can, provided that there's no compromise in the mental state or the urine output. If our patients happen to be hypertensive, we might suspect sort of rupture in them. And so for them, the first thing would be to get the intravenous fluids running, have a blood for cross-matching, and rush that person into surgery. Right, so now that we've discussed what goes on in the emergency room, let's talk a little bit about the surgical options. So we sort of divide this into type A and type B. The type A dissections are the ones that require surgical intervention. And so what this involves is a median sternotomy, initiation of cardiopulmonary bypass, and then the aorta is cross-clamped as high as possible. Now then there's excision of the intimal tear, and then the aorta is sort of then regrafted using a synthetic vascular graft, and then it's sort of reconstituted then. Now type B dissections, usually optimization of the medical therapy in the form of the antihypertensives seems most appropriate. However, surgical intervention is reserved for people who are then exhibiting either signs of impending rupture or signs of decreased perfusion. So there's this procedure called TEVAR, which stands for thoracic endovascular aortic repair. And it's less invasive than open heart surgery, I suppose, or open surgery. And so it's primarily for patients with complicated type B dissections. Now, because of high surgical mortality, today endovascular procedures are being performed for dissections. Now, what they do is that they enter the aorta and they put an endovascular stent in, and that covers the intimal tear. And so what that does, it essentially blocks off the lumen, the false lumen, and it has a lower morbidity compared to open surgery. So that's a plus point. Now, the outcomes, the prognosis for type A is much worse than that for type B. And if type A does go untreated, 50% mortality is expected within the next 48 hours, as 75% within the next 1 to 2 weeks. Type P does have a better prognosis. Generally, surgical mortality stands high at 20 to 25%. However, the overall survival for patients who leave the hospital post-surgically is at 80% for them getting to 5 years and 40% for them getting to 10 years post-operatively. Right, so that concludes our topic of acute aortic dissections. We have covered a basic introduction, the classification, clinical features. We've talked about the diagnostic tools and the differential diagnoses, the management, and also the outcomes. And the take-home point for this really would be is that there is a vast range of clinical features that come with this condition. And so it's really important to keep your eyes open for all of those. And that really it is one of those things that is frequently misdiagnosed. And so do take in what has been said today. And stay tuned to sqadia.com for more informative lectures on all the topics that you'd like to know more about. Thank you.